when they are in a septic shock. So, or especially in the old age patients who presents with morbid condition, with comorbids. So these all patients are at a high risk. And when going for the surgery in these patients, you have to take consent for high risk laparotomy. So never forget to explain on table death. These were the intraoperative complications. Now you have to discuss the early complications. There could be pain, there could be bleeding, there could be infection as well. Uh, the pain. Uh, Regarding the pain, you have to tell them there are the ways to reduce this complication or this risk. As we may offer patient an epidural or patient-controlled analgesia to minimize the pain, and we will also offer local anesthetic into the incision edges at closure to reduce the bone-related pain. Regarding the bleeding as an early complication of surgery, we can explain them that there is a small chance of bleeding and bruising in the abdomen post surgery. Depending on the reason for laparotomy, depending on the reason for bleeding, laparotomy packs may be left in place to arrest bleeding and remove the following day, example in liver trauma. It happens whenever the patient presents to us with liver trauma or spleen trauma, or we are going to operate upon that patient, and the bleeding is massive. So we peg that area and leave the peg as damage control surgery, and then remove them afterwards. Now discussing the post-operative complication. Never ever forget to discuss about the re-exploration of the patient. Uh, Please tell them that this occurs in 5 to 10% of emergency laparotomies. Could be because of anastomotic leakage or collections, or sometimes there is wound dehiscence that could be partial or complete. I mean, sometimes the patient may have worse abdomen. So there is always a risk of re-exploration. Anastomotic leakage. Anastomotic leakage likewise occurs in around 5% of emergency bowel dissection. And if this occurs, the patient usually require further surgery and stoma. Ileus is a very important post-operative complication, and regarding the ileus, we have to explain to the patient and to the attendants that as we handle the bowel during the approach, it can reduce the bowel mortality, and it can take several days to return to normal function. And to prevent it, we minimize excessive handling of bowel. Scarring as you know, a midline or transverse incision will result in a scar which may form a keloid, particular in high risk patients. There is all while in the laparoscopy, there is always, especially in emergency setup, there is always a risk of thrombosis. A deep venous thrombosis and pulmonary embolism are a possibility in any operation. So you have to tell the attendants that as you are going to open the abdomen of this patient, And these type of surgeries carries the risk of deep venous thrombosis and pulmonary embolism, um, and which is more in the patients who are suffering from the cancer and prolonged bed rest, and it causes the blood clots to form in the vessels of the lower limbs, and it could dislodge to the lungs, can cause pulmonary embolism. And to prevent this complication, we will give the patient anti-embolism statins, and we will also start low molecular weight heparin perioperatively to minimize this risk. And also consult them regarding the stroke, the myocardial infarction, renal failure, and death, because there is always a risk of these complications in patients undergoing emergency laparoscopy. And you have to also explain them the late complications of the laparoscopy, that is post-operative hernia, or there could be the adhesions. So please explain them that any laparoscopy incision has the potential to cause a hernia in the future. And how will you say them or you advise them that how can we reduce this risk? Please answer. What will how would you explain them that there are the potential ways to reduce the risk of hernia formation? Yes, I'm waiting for the answer from you people.
Hello, madam. Hello. Hello. Hello.
Yes, I'm sorry.
Okay, madam. स्टार्ट कर दीजिए.
Connection errors. Hmm. I'm sorry. So we were discussing about the late complications, and I was telling you that you have to explain them regarding the complication of hernia, and you will explain them that any laparoscopy incision has a potential to cause a hernia in the future. So how can you reduce this risk? We'll advise the patient to avoid heavy lifting for 8 weeks post surgery. And then the other late complication is adhesions. So explain them that abdominal surgery may cause adhesions as a reaction to the procedure, which can result in additional bowel obstruction months to years after the operation. So now, to summarize, you, ha- uh, you have to say to the patient that even with proper care, you can develop serious complications. We will try to minimize your exposure to the complications and let's work together. Uh, Breaking a bad news is a very important component of counseling. And for you guys to remember it, here is a protocol, the spikes protocol, SPIKES, the spikes protocol. Here S stands for setting, P for perception, I for invitation, K for knowledge, E stands for emotions and empathic responses, and F stands for strategy and summary. So S stands for setting, means setting up the interview, introducing, preparing, and planning of the space. The presence of a hello, the presence of others, the sitting arrangements, and managing time constraints and interruptions. So means before breaking a bad news to the patient, you have to make the atmosphere comfortable for the patient as well as for the attendants. Then here is the P. P stands for assessing the patient's perception, finding out how the patient perceives the medical situation. You have to ask him what does he or she knows about his disease. As for invitation, you obtains the patient's invitation to the type and depth of information they want to receive. K stands for providing knowledge and information to the patient. You have to share the information with the patient in a tailored level of communication and vocabulary so that he or she understands it completely. Then comes E, addressing the patient's emotions and empathic responses. Responding to the patient's emotions with empathy. You have to show your empathy to the patient that I realize or I understand your feelings, but we have to do this. And lastly, strategy and summary. You have to plan the next steps, setting goals and treatment plans, and establishing the follow-up. This is especially useful for patients who presents to you with bowel perforation secondary to malignancy. And here you have to break bad news to the patient. So while breaking a bad news, always follow the spikes strategy. It will help you out. And I'll after having my PowerPoint presentation, I'll show you the video uh, how to break a bad, how to breaking a bad news. Okay, now I'll show you the videos. Do you have any query?
What would you say if you were asked to give your informed consent?
मैम स्क्रीन शेयर करें। आपने जो वीडियो जो ऑन किया ना उसकी स्क्रीन शेयर कर दीजिए।
Hmm?
आपने मैडम कोई वीडियो चलाई है?
हाँ, वीडियो ऑन की है, लेकिन ये स्क्रीन पर शेयर हो रही है या नहीं?
नहीं हो रही है मैडम।
तो इसको न्यू शेयर पे जाके
जी मैडम, न्यू शेयर पे जाइए। अब आइए मैडम।
thank you. Now, here is the video which will clear your concepts regarding the informed consent.
What would you say if you were asked to give your informed consent? Would you say no? Would you say yes? How would you decide? You might be asked to provide informed consent when a health provider would like to start a new medical treatment, or when you are asked to participate in research, or for other reasons. What does informed consent mean? The word informed comes from the word information. Informed means that you have all the information you need to say yes or to say no. Consent means that you agree, you say yes. So informed consent means that you agree to do something or for something to happen because you have all the important information about that thing and you know what it is about. To give informed consent, you need to know some important things. What is it for? How will it happen? What is good about agreeing to this? What are the risks? How will information about you be collected and shared? Can you say yes and then change your mind later without any problem to you? It is up to the person asking for your informed consent to give you all the information. When you understand this information, then you can say yes or no. If you say yes, this is informed consent. You do not have to say yes or no straight away. You can take your time to think about it. You can ask more questions. You can talk to others about it. No one should put any pressure on you to say yes. You can say yes or no whenever you are ready. It is up to you. Informed consent in a patient's shoes.
मैडम स्क्रीन शेयर कर दें.
हाँ अभी कर रहे हैं.
Informed consent goes something like this.
Here is another video showing you informed consent, the value of informed consent.
Informed consent in a patient's shoes. Uninformed consent goes something like this. Okay then, Mr. Miller, we've had your blood test back, your white cells and CRP are up, so we do think it's appendicitis. What we can do for you today is take you for keyhole operations, take your appendix out and get you better again. Okay, it's a fairly low risk operation, just a few cuts in the tummy. There's some risk of pain, bleeding, infection, and there's a risk of heart disease that. I've signed in today. Okay, and we'll get you up to this and get that done today. We'll see you in pictures.
Who is she? What's CRP? What is that? What is keyhole surgery? What? How about that surgery?
Valid patient consent requires information and understanding. Not all patients feel empowered enough to ask doctors questions or to let us know when they don't understand. Hello again, Mr. Miller. I'm Ellen Jerome. I'm one of the surgeons working with Mr. Phil Potley consultant on call today.
Hello, doctor.
Hello. We've had the results from your blood test back. Some of the markers of infection are raised, which supports the diagnosis of appendicitis. And what we probably recommend for that is a operation, a laparoscopic appendicectomy. Do you know anything about the appendix or appendicitis?
Not a lot.
Okay, I'll tell you a bit about it now. Like if I just sit here.
Please do.
So imagine this is your body. Okay, your legs. Belly button's there. Just a few minutes of explaining to the patient what's happening can make all the difference. Okay then, Mr. Miller, so just to summarise, we talked about appendicitis and why we recommend removing appendix to treat it. We talked about what your recovery is likely to be, a bit about how we do inflammation. Do you have any other questions for me?
No, doctor, I feel very well informed. Thank you very much.
I've written out what you said for here, so if you just sign on the line. And we'll see you a bit later for the information.
Thank you.
These simple steps can improve our patient's understanding. Introduce yourself. Assess prior knowledge and give the information accordingly. Use visual aids. Avoid medical jargon. Summarize. Offer the opportunity to ask questions. And with patient understanding comes patient empowerment and trust. what it feels like. You've been studying hard in med school, but it's your classmate who keeps